what I do is probabilistic risk assessment, but not like traditional statisticians or even traditional Bayesians. It's all about looking at causal models and the so-called smart data approach. And we're talking about doing decision support and prediction, and ultimately we're looking at improved medical outcomes. I mean, we don't just do decision support in medicine, but a lot of our stuff at the moment is there. But it's about doing it, the ultimate aim are improved medical outcomes and more efficient use of resources. And so it's about, how do you get the improved decision support and prediction to achieve those goals. So what it boils, the problem about this whole problem about where the limitations lie it's been very well expressed recently by Judea Pearl in the so-called ladder of causation. So Judea Pearl is considered to be sort of one of the fathers of AI and causal modelling. He's a Turing Award winner, and I think he puts this very well. And our work very much fits into this philosophy. So he talks about there being the ladder has there's three rungs to this ladder, okay? It's seeing, doing, and imagining. And basically, at the bottom rung of the ladder, it's all about association. So what if I see? So from Charles' data, for example, is this drug effective at stopping headaches? So this is essentially the kind of like the association step. Of course, what we want to do is get to the intervention step, which is what if I do? So if I take this drug, will it stop my headache? And at the top level, the imagining level, is the counterfactual level. So what if I had done? So if I hadn't taken this drug, would my headache still have stopped? And what Pearl argues, and I strongly agree with this, is that standard statistical methods are machine learning. And in fact, basically, this is the problem. Most of what currently goes under the guise of AI in medicine, unfortunately, right, can only really answer questions of association. Right now, there are issues about whether randomised controlled trials can get you properly to level 2, and Pearl maybe would argue more strongly than me that absolutely it doesn't. Of course, this doesn't mean that you don't get some incredibly powerful results using purely machine learning from big data in areas like epidemiology and medical imaging, because you do, but you can actually do even better if you take a causal approach, which is Pearl's solution to getting, which says the only solution to getting to the higher ladder, the higher steps on the ladder of causation. And so, so typically, I mean, this is a very simplified. This actually does actually originate from a real study, but it's a very, very simplified example, just to give you a feel of what we mean. This was you take, for example, some basic. Let's say you're trying to learn from information about patients who come into trauma, A&E with trauma injuries, head injuries, and you're trying to learn information you might have available at entry, so some basic sort of life signals like this. You're trying to learn who are the patients who are basically most at risk, let's say, of dying in the first 24 hours, and therefore who are the ones who need most urgent treatments. It's a classic risk assessment problem, and the way that so you've got that data, and you collect data for thousands of patients who've come in, and you look at the outcome data, whether they did or they didn't survive, right? And essentially, what the classic machine learning tools are doing is essentially they're doing some, I say regression modeling. Actually, every statistical modeling approach is essentially doing this. It's doing whether it's support vector machines, whether it's neural networks, whatever it is, it's doing it's just trying to learn some sort of clusters or learn the relationship, or even it's basically curve fitting, right? You're trying to learn from that information to help you better predict, the outcome, what the outcome is. And of course, it takes they do reasonably well. Look, it does better than not doing it, than not having any model at all. There's no doubt about that. You can get pretty good results, okay? But these results are always limited, and you always get, in this case, like strange outcomes. Like it appears to be the case that actually the people with the most sort of at-risk factors, when you look at it, actually then tend to do quite well, maybe better, than some who don't seem to be as at much risk. That's what the data tells you when you've got this data. And there's a very simple causal explanation for all of this, right? But because basically you need a proper causal model for this, and the causal model would look like something like this, that things like injury type, classification, that is, of injury type, and the delay in arrival, that tells you something about the seriousness of the injury. There's a kind of a latent sort of expert variable there. We haven't got data on that. And of course, what these other things are, they're just symptoms. They're just test results which are symptoms of this seriousness of the injury, right? And of course, things like maybe your age and the seriousness of injury is basically affecting your ability to recover. Okay, and here's the crux. What happens is, of course, that when in the A&E centres where this data has been gathered from, the doctors, the surgeons know. They just know when a patient needs urgent treatment or not, right? You know, it might be from these, it might be from the symptoms or whatever, right? They will know. They'll already know, and they will give They will give the necessary urgent treatment to the patients who are most critical. And of course, that's what's explaining. That is explaining part of the data, but it's explaining that sort of that missing data about why is it we just don't get this right? Why is it we're missing at the kind of like extremes? And what we do effectively, this is a causal model, and when you add a probability calculus to that, you get what we call a Bayesian network, and you can actually do the combination of the data that you have got, right, to learn some of these relationships, but the additional data you need to get, which is essentially expert judgment about these things that you haven't got the data on. And there's a very interesting thing here. That the fact that we didn't have the treatment data, who was given urgent treatment data, is we've seen that type of thing a lot in the medical in the data for medical studies that we've looked at. An obviously critical missing factor. But that's one you can get. You can then recover that. And actually, what happens is you basically can have. We build these models. I won't go into detail. This is an example of a Bayesian network, but so from the actual data, this is a situation where you've actually got this is a worst case person, sort of elderly person. All the factors are bad here, right? So actually, hidden from the original data is the seriousness of the injury and the low probability of recovering if you don't do anything. But of course, we are going to do something. In most cases, from the data alone, we can see that 90% of the cases where people had that profile, there was the urgent treatment was applied, and that led to a better outcome than would have been expected if they hadn't had the treatment. The data doesn't tell you that, the original data, but this model does. And this model enables you to effectively hypothesize about what would happen if we do the treatment. That's the next level. Just have a look at this. The probability of the treatment in that case was 90%, and there's a 73% outcome. If we slightly change this, where we've not got such a bad situation, you see the problem that the data. This was a situation where the outcome wasn't as good as in the worst, the more seriously affected person. So, although I haven't showed you, this is just a flavour. These Bayesian networks do enable you to explicitly model causal factors, intervention, and counterfactuals. And I actually think that the kind of study where this would be very important is like, for example, in Harriet's study, I think, and the questions that were asked afterwards are raising a lot of these kind of like causal factors and potential interventions at different stages for which the data isn't there, but which you have to, I believe, build this type of causal model rather than relying on pure data. You can reason from effect to cause and vice versa. We could also reason from symptom or outcome back to the actual profile of the person as well, rather than just doing a prediction. I didn't say much about that. We can incorporate these latent variables. You can make predictions with incomplete data, combine different types of evidence, and it's also a very visible tool. It gives you a real understanding of what's actually going on here. And again, this is something we deal with, especially not so much in the health area, but this is something we deal with sort of major sort of critical events like sort of terrorism or transport failure. So it's also very powerful in that area. So I mean, as an example, you can actually see one of these models. There's an online version. We work with the trauma surgeons, actually the people at the Royal London who deal with sort of amputations, and there's a classic, there's like classical statistical models were subject to all the problems with the data and all that, and we were able to do a lot better with these models by getting adding the expert input than the pre-existing purely statistical models. So you're okay, but you can always do better once you add the causal modelling and the expert judgment. So if you really want to play with this, it will give you these sort of risks and stuff like that. So you can play with that. I do declare an interest here because I'm also a director of a company called Agena, which actually does this sort of Bayesian network modelling and has a tool, and that's indeed powers that particular tool online there. Just one more thing for concluding. At the moment, I'm currently PI in one of these EPSRC health technology projects where we're actually doing this sort of causal modelling to add intelligence to sort of home monitoring type systems for chronic diseases. So again, it's moving beyond, it's getting to improve, what I said before, improve decision support, improve prediction, with the ultimate aim of improving medical outcomes and making more efficient use of resources. 2 studies there, in particular, rheumatoid arthritis and diabetes in pregnancy, gestational diabetes. So in summary then, yeah, big data, okay, I mean the point is, you can apply these techniques, and in most cases, well not all cases, but you've got to be careful about what you end up with, purely from the data alone. So it's that combination of big data and knowledge. Sometimes you need to throw away most of the data that actually you think is the big data. Actually, you might need to get some extra data, and you might need to have some pure expert knowledge added. And when you pull that into these causal models, I think you get better results, and there's some follow-up material if you're interested. And I hope presumably all the slides will be available online, so thank you very much.